Welcome back to another edition of Optimal Anesthesia. The complexities of cirrhotic cardiomyopathy, CCM, are going to be explored in great detail today. In what ways are anesthesiologists involved? Think about the challenges of maintaining a patient's anesthesia while this quiet disruptor of the heart environment is there. Discover why knowing CCM is crucial for success in our profession. Cirrhotic cardiomyopathy, often lurking silently in the shadows, impacts up to 50% of cirrhosis cases. Cirrhotic cardiomyopathy isn't your average heart condition, it's a puzzle that has intrigued the medical community since its revelation in 1953. As an anesthesiologist, you know the crucial role the heart plays in the perioperative period. Picture impaired cardiac responses, a hyperdynamic circulatory dance, and the enigmatic QT prolongation, all influencing your anesthesia management. But why does this matter in the world of anesthesia? CCM tends to mask itself under stress-induced manifestations, making preoperative assessment challenging. The risk factors, such as alcohol use disorder and hemochromatosis, further complicate the picture. Liver transplantation, a potential solution, introduces its own set of challenges, and without a standardized treatment, our role becomes pivotal in unraveling the mysteries of CCM.
We are demystifying the intricate pathophysiology of cirrhotic cardiomyopathy. Think of it as a dance performance, one that starts with grace but takes unexpected turns. Let's start with the conductor, your heart, facing confusion in the form of autonomic dysfunction, changes in cell membrane, and ion channel defects. Imagine a conductor trying to lead an orchestra, but the notes aren't quite right. Now, picture the blood vessels as the grand stage. Vasodilation, driven by nitric oxide, carbon monoxide, and endocannabinoids, opens the curtains for an easier performance. Less resistance means the heart's dance is smoother when things are calm. But as any dance goes, there are intense moments. To cope, the conductor activates a backup team, the renin-angiotensin-aldosterone system and the sympathetic nervous system. Unfortunately, this leads to a chronic dance, making the conductor a bit tired. As the dance continues, a plot twist emerges. Elevated cholesterol content disrupts the performer's moves, causing a misstep in the dance routine. Now, the dance takes an unexpected turn with a decrease in certain channels, leading to a prolonged dance move called QT prolongation. It's like the orchestra playing a bit too long, creating an unusual rhythm. Suddenly, there's chaos with calcium coming in uninvited, causing some performers to leave the stage, a phenomenon known as cardiomyocyte apoptosis. Structural changes unfold like a shift in the stage's shape, eccentric left ventricular hypertrophy. The heart struggles to relax between moves, leading to diastolic dysfunction. As the dance progresses over time, fatigue sets in, a result of impaired energy metabolism. The conductor, your heart, faces a challenge in maintaining the same level of energy.
Imagine the heart as a master conductor orchestrating a grand performance. In the realm of cirrhotic cardiomyopathy, it often operates in silence, thanks to compensatory peripheral vasodilation. However, stress-induced dynamics can reveal acute heart failure symptoms. Keep an eye on patients with advanced cirrhosis, showcasing exercise intolerance or fatigue without apparent cardiac disease. Our conductor's demeanor is often unremarkable at rest, like a calm before the storm. Yet, under stress, signs of congestive heart failure emerge: peripheral edema, jugular venous distension, and the distinct third/fourth heart sounds. It's a delicate dance, accompanied by clues of concurrent liver disease during examination.
Picture your heart as a conductor, orchestrating a grand performance. In cirrhotic cardiomyopathy, it operates in silence, thanks to compensatory peripheral vasodilation. But stress can reveal acute heart failure symptoms. Keep an eye on patients with advanced cirrhosis. They might exhibit exercise intolerance or fatigue without apparent cardiac disease. Let's uncover the details of this intricate evaluation. During a physical exam, the heart may seem unremarkable at rest, but signs of congestive heart failure may appear under stress. Look for classic findings like peripheral edema, jugular venous distension, and distinctive heart sounds. Don't forget to note concurrent signs of liver disease during examination. The evaluation criteria from 2005 WCG become our scoring sheet. Systolic dysfunction evidence includes a blunted increase in cardiac output and a left ventricular ejection fraction below 55%. Diastolic dysfunction has its dance, with an E/R ratio of less than 1, prolonged mitral deceleration time, and isovolumetric relaxation time. Laboratory workup involves confirming cardiac involvement with atrial natriuretic peptide, ANP, brain natriuretic peptide, BNP, or its prohormone N-terminal proBNP, NT-proBNP, troponin I, and optionally galectin-3 as a marker of cardiac fibrosis. An electrocardiogram, EKG, reveals early signs of QT prolongation. Monitor diurnal variations due to changes in autonomic nervous and circulatory systems. Chest X-ray, typically normal, may reveal cardiomegaly or pulmonary edema. But the real star of the show is echocardiography, essential for diagnosis. Assess diastolic and systolic dysfunction and use speckle tracking for further ventricular function analysis. Stress tests confirm the diagnosis by demonstrating a blunted cardiac response consistent with CCM manifestation under stress. Whether chemical or exercise stress tests, they're conducted under controlled conditions. Next, we're exploring the complexities of cirrhotic cardiomyopathy and its management plan. Let's unravel the layers. Our first point in managing cirrhotic cardiomyopathy involves what we call the maestros of medications. Picture this: our ensemble of medications includes ACE inhibitors, ARBs, diuretics, and the star performer, carvedilol. But, hold on. There's a twist: caution with ACE inhibitors in certain scenarios. It's like finding the right balance in our musical composition. Now, let's talk liver transplantation, the grand crescendo in our management symphony. This isn't just about the liver, it's a heart and liver duet. We consider indications like systolic and diastolic dysfunction, adding a bit of suspense. And the timing? It's like choosing the perfect moment for a musical climax. Will the cardiac benefits hit the right notes within 3 to 12 months post-surgery? That's our cliffhanger. Moving on to what's not on our playlist, tips placement. It's like trying to fit a saxophone into a violin concert. It just doesn't harmonize with our goal of improving cardiomyopathy. Follow-ups, our post-performance encore, involve monitoring cardiac function and tweaking medications based on the post-transplant melody. It's all about fine-tuning for the perfect harmony. Imagine a symphony where each instrument plays a crucial role. In our collaborative approach, hepatologists, cardiologists, and transplant specialists join forces, creating a musical masterpiece. Continuous communication is our secret ingredient for an unforgettable performance. Now, let's educate our audience. Adherence to medications is our musical score. We want every note to be played just right. We educate on potential side effects. It's like guiding our audience through the emotional highs and lows of a performance. Lastly, our encore is dedicated to research and innovation. It's like exploring new musical genres. Ongoing studies bring fresh tunes and rhythms to the ever-evolving world of cirrhotic cardiomyopathy. That's a wrap for today on Optimal Anesthesia. Thank you for joining us as we explored the vital role of anesthesiologists in deciphering the mysteries of cirrhotic cardiomyopathy. Stay tuned.